Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins plastic and reconstructive surgeon Dr. Michelle Manahan will be speaking on new horizons in breast implants, busting myths and embracing innovation. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback at hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Michelle Manahan to begin our presentation.
Hi there, everybody. So nice that you were all able to take the time out of your busy days to join me. I'm looking forward to spending the next roughly hour with you all. And I wanted to just start by telling you who I am. My name's Michelle Manahan. I have been working at Johns Hopkins as a plastic surgeon now this is the 19th year that I've been in clinical practice. I was at Johns Hopkins for residency and medical school before that, so I've been around a while. Seen a lot of stuff in breast reconstruction, so hopefully, as well as breast augmentation, et cetera. So hopefully talking about breast implants today will help anybody out there who has questions about whether these types of things are right for you or for loved ones. And I'm looking forward to sharing information, but what I'm really looking forward to is the question and answer time, because I think we can really shape what we have to talk about to what you all want to hear about. So with that, I will get going into the meat of it. I think that it could be that all of you out there are really experts in terms of breast implants. Maybe you have a breast implant, maybe you know family members or friends who have breast implants, or maybe you've just been doing a lot of homework on the internet and talking to others. Maybe you've seen physicians before and you know a lot. But there are probably some of you out there who just aren't sure a whole lot about what we're thinking of. So I wanted to just take a few minutes to talk about the basics of breast implants. So essentially, a breast implant is a device. It is, and that's why here on the screen we'll get into what they are, what they aren't. They are a medical device. The FDA does keep an eyeball on breast implants. And essentially, this device is just a plastic shell. It's a silicone shell. They all have a silicone shell. They then are filled with a couple of different types of materials. One is saline salt water. That's what the body is made of, 97 or whatever percent of the body is salt water. And the other is gel. And different descriptions are out there about what that gel is like. And you can probably think of it on a spectrum of things from about the consistency of firm Jell-O up to something that's more like a gummy candy type situation. So the silicone shell encompasses either the saline or the silicone gel, and then the shell has different properties. There are a few implant companies out there, and each one has their own sort of private method of making these devices. But essentially, the shell can be smooth or it can be textured. Smooth is like a baggie of water. It's like a Ziploc. The textured is more like plasticky sandpaper. And there are different reasons that different implants have been used over time. And we'll talk a little bit about why maybe some implants are getting used more or less currently than they used to be. The shape of an implant can be either round or like a teardrop. And we think of a teardrop shape as more what the natural breast is shaped like. So there's some indications for a teardrop implant. But then we also think about the fact that this implant, when it's in place, isn't stuck in place, so it may wiggle a little bit. So sometimes if you think about you don't want a natural breast shape to be twisted, there are indications for a round implant also. So if you're out there thinking about embarking on an implant journey, these are the types of things that you'll probably be helping your healthcare provider make a decision about. What's the shell of the implant? What's inside the implant? And what's the sort of type or dimensions of the implant? So, with that kind of just level setting experience, now we're going to move on to specifically what do we think about when we're talking about breast implants? So, what they are is a valuable reconstruction or aesthetic option. Patients may have very small breasts and be looking to enlarge just for aesthetic purposes, or they may have lost portions of the breast or all of the breast due to diseases like cancer or other tumors or trauma, and that implant can help fill volume for the breast. They are widely used, both within this country as well as internationally. They have been used for a really long time. Now, the devices have evolved over time, so an implant from 50 years ago may not be the same type of implant that we're placing now, but breast implants, plastic devices going into the chest, have been placed for a really long time. As I already mentioned, they are medical devices. So, this is something that is important to think about. It is important that external bodies look at this, regulate this, keep track of this. And for us in the US, it's the FDA. Now, as we talked about, this is a piece of plastic, and it's a piece of plastic that's being put into the body, and it's indwelling and it stays in there, theoretically for many, many years or kind of forever. So just like if you had a little pebble that got stuck when you cut yourself, fell and scraped your knee when you were little, and a little pebble sat in there and you could kind of feel it under the skin, and maybe it's just not what the body's made of. That's the same with the implant. And this has a couple of different things that we think about. So, a foreign body can do different things to the soft tissue, the healthy living body tissue around it. There can be we'll talk about some of the negative stuff because we want to know goods and bads about what we're thinking of. A foreign body can be more prone to an infection. So, say you get your teeth cleaned and the germs kind of shoot through your bloodstream and pretty much your immune system cleans them all away. Well, those germs might find a happy home sitting on an implant because those white blood cells that fight infection in the body aren't really able to get to that plastic sometimes. So we do think sometimes that implants are a little bit more prone to an infection. And because they're a foreign body, the body senses that and may form and usually, not may, but usually forms a little capsule around it. So that's like an internal skin almost that's formed around the implant. And that has a component of inflammation to it. And that capsule that forms usually is just very natural, very soft, but occasionally the body keeps forming that. So sometimes it can form firm tissue around an implant or even some concerning tissue around an implant. So those are things to just kind of be aware of. The implants are not as diverse as the human body. So, I do a lot of breast surgery, and I will say that no two breasts are alike, even on the same person, but definitely no two chests are alike between different people. So we have sort of an infinite variety of breast needs, but a limited variety of implants, shapes, sizes, dimensions that can try to meet the needs of the infinite variety of breasts that we're trying to work with. So there's just as you're if you or, anybody else thinking on this webinar is actually talking to a healthcare provider about yourself, you may recognize that there are some choices that might need to be kind of discussed, compromises made in terms of what do we have available for you and what do we really want to have. And I would say that this implants are big business. So the companies are always trying to work toward building a better mousetrap. So constant innovation, working toward what the shell is, what the fill is, what the dimensions are, making bigger implants than previously were made, different dimensions, so that we really can move forward and have more and more variety to meet those various needs. Just to think about a little bit, though, that an implant is not necessarily a set it and forget it type situation. It is not a forever answer to whatever the problem or question is. Implants don't last forever. We say in clinic, they're like a car tire. They do go flat with time. So when an implant is placed, we need to think that at some point down the road, and we're always hoping it's longer rather than shorter down the road, an implant may need to be replaced. The average teaching for how long an implant lasts is about 10 years on average. So we think that, well, if it's a 10-year average, then some patients may be on the short end of the average, get a lemon, have to have it exchanged earlier, while other patients may be on the longer end of the average and be able to go a couple of decades, more than a couple of decades, without having a problem that requires surgery. And we'll talk a little bit more if we want to later on in terms of the types of implants that we're using more or less of and the imaging that may or may not be recommended to go along with that. Because if I was sitting there listening, I would say, well, how do I know? How do I know when I need surgery? Because I don't want to have more surgery than I need. We usually counsel patients at Johns Hopkins that you don't need to have an implant exchange unless there's a problem with the implant. So sometimes it's a problem with the implant itself, it's leaked. That would be when we exchange. It's not like you hit the 10-year birthday for the implant and then you have to have surgery just to update it. It's really only when there's a problem. And then sometimes it's not the leak, but sometimes it's, the like we mentioned, that firmness of the soft tissue. Sometimes it's firm, sometimes it moves a little, sometimes it just has gotten different. Say if it's on just one side, maybe for a reconstruction, maybe the other more natural breast has changed some over time and the implant has changed less. So we want to work on symmetry. There are a million reasons why you might or might not, with an implant, want to consider revisions. So, like we've talked about, it's not forever. It's not perfect. It's not set it and forget it. And, nothing we do in medicine, unfortunately, is without risk. So there are always some things to think about. And that's where I really want to sort of pause and talk about what are the current things that we're thinking about, because we are constantly, like I mentioned, the implant companies constantly working to innovate and build a better mousetrap. Well, as healthcare providers, we're constantly working to figure out a better way to use the tools that we have. So we have talked more and more over time about a couple of scary things: breast implant associated illness, as well as breast implant associated cancers. And I bring it up again, not to be a rain cloud, but I think it's important that anyone who has an implant or is thinking about an implant for themselves or those they care about hear about these things and be able to process them, hopefully, before you're faced with the decision about what do I do, because it's just nicer to have kind of the mental space to think about things ahead of time. So, breast implant illness. It is something that is probably not very well understood currently, and there's a lot of studies that are being done on it. So over time, I can be fairly sure that we're going to know more in the future than we know now about breast implant illness. But in my mind, I think of it like an allergy. So while lots and lots and lots of people can eat shrimp, but some people can't, lots and lots and lots of people can tolerate implants, but it looks like some people cannot. And if you're wondering, well, what does it look like if I can't tolerate an implant? I would say that breast implant illness presents as just a huge variety of different symptoms. Probably, again, no two patients are alike in terms of how they experience this situation, but a lot of times it's symptoms that range from head to toe that maybe are a little bit more difficult to put a finger on in terms of other diagnoses. A lot of times patients will sort of see other doctors for workup for things like arthritis or fatigue or changes in kind of mental acuity and kind of go through a lot of workups, but not really get a really strong definitive diagnosis as to why they feel the way they feel. And then patients may say, "Well, I do have these implants," and there's the breast implant illness is a possibility. So if a patient elects to remove an implant, we are doing it with the hope, fingers, toes, and everything we've got crossed that this will improve the symptoms, and it can. It can improve symptoms when you have breast implant illness and the implant is removed. Sometimes the symptoms don't get better, and we don't know, is it because of the history of the implant? Is it because there's actually something else going on that we don't know about? So it's a very nebulous thing, very hard to really get a handle on and really say, this is what it is, this is not what it is, this is what needs to be done, and this is the person who needs to have that done. But certainly it's something to make sure that anybody who has an implant is well plugged into working with their healthcare team to make sure that there's ongoing conversations. That's kind of what I want to convey about this whole thing. When there's an implant in place, it's going to mean ongoing conversations with your healthcare team. So, another side point, make sure that you feel comfortable with your healthcare team. Make sure that the people who are doing the surgery and providing the care have the right credentials, have good training in authorized training programs, and are board certified or board eligible in the appropriate boards that relate to plastic surgery. The other thing to think about, I mentioned breast implant illness, but the other thing that is kind of more commonly thought about and also scary is breast implant associated cancer. Now, the one that's been talked about the most is breast implant associated anaplastic large cell lymphoma, BIAALCL. It's a mouthful. Essentially, it's not a breast cancer. It's a cancer of the lymphatic system that presents in the breast, and it can be dangerous, but it also can be very treatable. And it is something that if you're experiencing any unusual symptoms, often it's a swelling of the breast late after an implant has been placed, but it can be something else. But if you're having any kind of concerning symptoms, either early after an implant is placed or long after an implant is placed, we all want you to get right back with the healthcare providers that you trust so you can work through it. Now, if anybody is out there and has a breast implant and has a swelling that occurred a while after the implant and you're getting scared right now, don't be scared because most of those swellings are not the lymphoma type cancer, but we just want to be aware of it and we want to be careful and we don't want to, sort of sweep anything under the rug and not know what we have to pay attention to so we can all stay safe moving into the future. So I would say those are kind of the two main big negative scary things that are out there that are being talked about a lot lately. Now, what about some of the better stuff? Where are we going on the happy front? I think that probably the most important thing in my mind that we've been doing differently lately, and not in the last year, but in the last several years, is thinking very carefully about what we're doing to the soft tissue around the implants that we're placing in the breast. So we have, anatomy wise, the breast skin, the breast gland, which is essentially glandular tissue and fat. So that's just that soft tissue that really is what we think of as making up the breast volume. And then underneath that, the pectoralis muscle of the chest wall that sits on top of the rib cage. We can put an implant under the breast gland, the soft, mobile stuff that we think of as the breast, or we can put it under the pectoralis muscle, or partially under the pectoralis muscle and partially under the breast gland. So there are kind of three choices. I would say that either under the gland or partially under the muscle are the two most popular choices, both in reconstruction as well as in aesthetic or cosmetic surgery for breast augmentation. We have tried to really anticipate what problems patients might experience that are kind of like, I like the way this looks, but I'm really bothered by X, Y, or Z. And one of the things that patients can be really bothered by is an implant that's either all the way or more commonly partially under the pectoralis muscle, and the jumpiness of the implant, say when a patient may be exercising and doing strenuous things that are causing the chest muscle to contract and the implants jump, and you can sort of see these maybe unnatural things. So because that's something that has really been coming up year after year, patient population after patient population in the US, internationally, there's been a shift to work to really try to, when possible, consider putting the implant not under the muscle, but under the breast gland, or at least less and less under the muscle. So, having less and less of that muscle pulled down, covering the implant. And that's to help patients feel better about the naturalness of the result they get with these types of surgeries. So that's something to think about if you're embarking on the implant journey. If you already have an implant in place and you're experiencing that, sometimes we can do surgeries to move the implant from underneath the muscle to on top of the muscle under the breast gland. And that's something that's an outpatient surgery, may take a few hours. There are goods and bads to it, but if you're having trouble with something, know that there may be a different answer now than there was several years ago. So that's something that I think is pretty important to address. Other things over time, and now I'm not talking a short period of time here either, but over time, we have worked to have more and more refinement in how we choose an implant. So we really want to think about how that implant, how that volume, generally round, because I should mention this. We are, at least in the practice that I work in, most commonly using smooth round implants now, because that breast implant associated cancer I mentioned does seem so far to be more commonly associated with texturing of an implant shell. So we've moved away from a textured implant shell just to sort of close the door on that potential risk factor. So in our practice, we're talking about how does this round, smooth-shelled volume impact what we see with our eye when we're looking at the breast. So there are a lot of things we have to think about. It's not just cc's. You'll hear, if you're in a consultation about a breast implant, you may talk about the number of cc's or milliliters. That's the volume of the implant. But that's really kind of just the most basic thing. There are things like the width of the implant, and we really want to think about the width of a patient's chest wall. We don't want to just put in any old volume. We need to think. Some of our patients have very narrow chest walls. We don't want an implant that's going to stick out way, way far and look unnatural or bump into the upper arm over and over. We want to have an implant that has a narrower base. For some of our patients who have a broader chest wall, we don't want an implant that's going to only affect half of the breast and then have sort of an unnatural step off with with the rest of the chest wall. So we really have to think about width. We also want to think about what is our patient's ideal in terms of breast appearance, because there are all sorts of different ideal breasts. Some patients like the more sloping contour. Other patients like I would guess I would call it more youthful, sort of fullness, more cleavage, more of the prominence of the front and upper part of the breast. And there are different ways we can work on that. So if somebody wants to really have prominent breasts, we want to probably have a profile of the implant that pushes forward more rather than spreads out. We also want to think about what's happening to the soft tissue that's housing the breast implant. So we're thinking more and more and more over time, how do we make sure that we have our implant the right volume, not too big that it overstretches the tissue? Because this soft tissue that's around the implant, the natural breast, we all know what happens to a natural breast over time for most of us. The skin stretches, the gland comes down, gets a little bit saggier over time than we start. With an implant under there, that may still happen. It may happen even a little bit faster if the implant's large and putting a lot of weight on the breast skin. So we want to think about what does that do for the long term and talk to patients who are young and healthy and luckily haven't had to think about the changes that time will do to their breast over time and really say, now let's think about what it means for the future because we don't want you to regret this 10, 15, 20 years from now. We want you to be happy, healthy, and like the choices that you made. So we think about what it does to the, we call, would say, soft tissue envelope. We want to think about where we're starting. Maybe we're starting with a breast that's a little bit larger or droopier than we really want it to be, and by we, I mean the patient and their loved ones. Then we think about, well, can we change the soft tissue on top of the implant? Because the implant, we want to sit up on the upper chest wall where the breast starts, and then we want to move the breast up to over top of it. So we're just having a lot more refined conversations with our patients about what they really are looking for now and into the future. And I think that's been a change because as much as we have tried over time to counsel everybody with all the information we have, it stands to reason we're learning more as we go in the medical field. So we have more to say about implants than we used to because we understand them better. So we're getting pretty close to that half-hour mark, and I really, really, really want to have the opportunity to answer any questions that you have. So my next few slides are just a couple of take-home points that I want you to remember, or at least think about remembering. Not meant to last forever. So an implant does mean maintenance surgery. Now, as I mentioned, it's maintenance surgery, but it's usually outpatient. It's usually, an hour, couple hours, nothing that's really very difficult for the body to recover from. But surgery is surgery and it means time out of normal life. And if this is happening at a later point when there may be new illnesses that weren't there when the implant was placed, it's all just a complex picture that we need to remember to have in mind. And I mentioned that I would talk about kind of how do you know when to have surgery? Well, if you're having trouble, think about it. But the other thing to remember is that the implant types impact how we monitor the implants over time. The saline implant, the saltwater implant, you kind of know if it's leaked because the breast deflates slowly over time. So the FDA does not recommend any routine imaging for a saline implant. Because the silicone filled, the gel filled implants are more cohesive, they kind of stay where they're put. And if they leak, they may not kind of move around very much. There may be a quote silent leak. So it is recommended that imaging be done. And these recommendations have changed over time. So I won't get into what they specifically are, but a silicone implant should be periodically imaged. So we know that it's not set it and forget it. The next thing just to remember is there can be dangerous things, not to scare anybody away, but we just need to know that there can be dangerous things that happen related to an implant, but we stay on top of it. We work to one, prevent, and two, diagnose early, and then three, treat successfully if bad things happen. And then, now I chose this. This is a photo from another surgeon, not anywhere in the area, but because I didn't want you to feel like, oh, I'm trying to sell you on my practice here or anything, but breast implants can do a lot of good. They can do a lot of good for patients who still have their breast, but just have been unhappy with the breast appearance. And they can do a lot of good for patients who have had to lose their breast or part of their breast due to cancer or other tumors or trauma or anything else. Breast implants are a very valuable tool that we have in our plastic surgery toolbox. So, those are the basic things that I wanted to get out there about innovations or things, the buzz currently about breast implants. So it looks like we've got our first question in. What happens to existing breast implants during radiation? Do they need to be automatically replaced? Very good question. And the simple answer is nothing remarkable happens to the breast implants themselves during radiation. You could probably argue that radiation isn't good for anything, so maybe it might make the implant age a little more quickly, so potentially it might leak sooner rather than later. But I wouldn't just automatically replace an implant after radiation. And in fact, radiation to the tissue means that we probably want to approach surgery more slowly rather than more aggressively. Because what's really changing is that soft tissue around the implant and that normal healing capacity of the skin and the other soft tissue is reduced a little bit after radiation. So we want to think and make sure that surgery really needs to be done and that we're going to see a benefit, a significant benefit, and we're going to maintain that benefit over time before we jump into surgery too quickly. So no, you don't have to, if you're having radiation or planning radiation, you don't necessarily need to think about getting stuck with another surgery just to get fresh implants in. The next question, let me see. I'm willing to do a breast surgery soon on the left side. And this question writer says that they already had a tram. That's that muscle flap from the abdomen on the right side. I'm assuming after for reconstruction after mastectomy, and it's shrinking. So the muscle flap is shrinking on the side that's already been done. Is it possible to add an implant to revise my reconstruction? And this patient has a history of the BRCA1 gene, which increases risk for cancers. It is possible to add an implant under an autologous or your own tissue reconstruction. And sometimes that's really the best answer. So it's, you all know. Everybody thinks about risk and benefit differently. Everybody is a different sort of level of gambler in Las Vegas, so to speak. But some patients say, I want the same thing done on both sides so that I'm moving forward with the same stuff and have more of a chance of a similar outcome for how the breast looks and feels. And that's okay to think that. And I would say that yes, it stands to reason that if you're doing similar surgeries, we're moving forward similarly. Except that surgery is not laser exact. So even if the same surgery is done at the same time on both breasts, the outcomes may be a little different. So I always hate for anybody to think about doing extra surgery just to have symmetry because we can't be sure we're going to get it. We think we will, but we can't be sure. So this is a different situation. This is where a patient may say, I have had to do surgery on the one side. Now I'm thinking about some other stuff. Or somebody might say, I only really want to work on the side that has to have the surgery. And I would really like to keep my own natural breast the way it is. I don't want scars. I don't want risk. I just don't want to operate on the other side. So that kind of plays into all of this. But it depends kind of a little bit if you're having an implant placed under your own tissue. It depends a little bit on the starting point of your own tissue. And while it's been shrinking, I wonder, was that muscle flap done a while ago? Because early on, after a muscle is transferred, because the muscle's not active, we expect that the volume may decrease a little bit. Sometimes the tissue is transferred with just the skin and fat and not really the muscle at all. So that can be a little bit more predictable in terms of volume long term. Another reason the tissue may shrink over time is it is living healthy tissue. So if the body has changed and maybe lost weight, the flap, as we call it, the patient's own tissue, may shrink a bit. It may have undergone radiation that causes tissue to shrink. So there are a variety of different things that cause that tissue to shrink, which may impact that decision about can I or can't I have an implant underneath. Simple answer is yes. More complex answer is maybe. And then, really trying to think about, particularly with the history of higher risk for cancer on the other, it sounds like your left side, what do you want to do now versus into the future? And our third question is, I had a large hematoma immediately post-op after bilateral mastectomies, requiring hyperbaric oxygen for weeks and 2 debridements. What is the likelihood of that occurring again after reconstruction? And at baseline, this patient has a little bit lower than probably average platelets, but this patient does clot easily. So, this is really getting into sort of a question about when do we worry about what type of complications? And what I would say is my hope is that my job is to do all the worrying for my patients and have my patients not do too much worrying because I I think that the worrying and the trying to sort of think ahead can do a lot of good, but it also kind of raises the stress level and that changes the stress hormones and maybe even makes you feel a little sicker around the time of surgery. So I think planning as much as you can ahead of time and then sort of sitting back and letting the body do its thing is good. But that's a little off topic from this question, but I did want to make sure I got that out there. So this complication, the trouble with healing, the bleeding, the trouble with healing that needed debridements, it's most likely to happen at the time of the mastectomy because it's just anatomy. Naturally, big blood vessels are going to the breast gland and the breast skin through the breast gland. They're coming out from the pectoralis muscle, from the chest wall, out to all that healthy soft tissue around it. When the breast tissue is removed, those main channels of blood supply are interrupted. So all that's left to heal the skin after a mastectomy is a little trickle. You can think of it like lace, a capillary lacy network, little trickle of blood coming in from the edges of the mastectomy. So sometimes that distance that random lacy pattern of blood vessels has to travel is too far for the blood supply to reliably get from its source at the edges all the way to the incision or all the way through the soft tissue to allow something to heal without bleeding, without skin changing and suffering. So most of the time, we worry most at the time of the mastectomy. And even with a history of healing trouble or a history of a hematoma, we hope that with subsequent surgeries, that risk decreases because the major impact to the main blood supply has already been taken care of. And the body adjusts over time, it adapts. And that lacy trickle of blood supply that's working after the mastectomy sort of becomes stronger. Never maybe as strong as the main channels that used to be there, but it gets stronger. So I would say, um, don't necessarily let your unfortunate history of problems impact you too much in terms of thinking of moving forward. Now, sometimes it's just not the right time. Sometimes those types of things just really weigh on a patient, and you just feel like I don't think I can embark on these things again. And that's fine. It's fine if that answer is never. It's fine if that answer is just not right now, because a lot of things that we do in breast reconstruction can be done in the future. They don't have to be done right away in a hurry. We like to move through things quickly so that our patients don't have to keep having a bunch of stuff on the radar screen. But it's not, it doesn't mean that you can't do something in the future if you might just want a break right now. And then our fourth question is, can you take out implants and then fill up the breast with body fat instead of new implants? Yes, you can. The different type of so the two main types of we're talking now after a mastectomy, after a breast has been removed, two main types of reconstruction: an implant using your own tissue an implant or using your own tissue. Using your own tissue has the disadvantage of new scars, a donor site. There's a different part of the body that has to have tissue removed from it. So that comes with a host of issues. Um, Generally successful, but a different set of things to think about. But sometimes patients really don't like the look or the feel of the implant or this worry about the, future screening or maintenance surgery and would like to switch over to your own tissue. The your own tissue kind of has bigger time and healing investments around the time of the surgeries, but when successful, which it is the vast majority of the time, it kind of grows old with you. So there are goods and bads to both. But yes, if someone has had a mastectomy or is facing a mastectomy, you can change the type of reconstruction you have if you either want to or need to. And then how do mammograms work with implants, which is a really good question. So not all of these have been really good questions. But this one sort of is important to think about for both the aesthetic and cosmetic surgery as well as the reconstruction surgery. So, a lot of times after a mastectomy with an implant in place, mammograms aren't necessary because the breast has been removed. Now, I'm just the plastic surgeon, so you don't want me telling anybody whether or not you need a mammogram after cancer diagnosis and mastectomy. But a lot of times, patients are not recommended to have those. So, that sidesteps that question. The surveillance imaging is for the implant itself. Now, for a cosmetic implant placement, there will need to be a mammogram frequently with the usual sort of recommendations from the other healthcare providers. And because the breast is, natural and on top of the implant. So the mammographers do special displacement views to sort of kind of try to get as much breast gland visible in the mammogram as possible, even with an implant in place. So it may mean a little bit more manipulation, and it may mean that a little bit of a component of the breast gland, there's a little less ability to see some of that breast gland with the breast implant in place. Our next question is, what should I expect during recovery? Ah, well, I would say that the easy answer to this is for most surgeries, we recommend, even if I take a mole off of somebody's arm, a little tiny mole, I recommend protecting the site for 6 to 8 weeks. Now, after radiation, if we're on the reconstruction side of things, that might be more like 8 to 12 weeks. So, really, we want the bottom line here is that the body takes about a year to heal to the maximum strength that it's going to be after it's had a procedure done. But the biggest time frame for the bulk of that healing is the first couple to few months. So that's why we say protect it as best you can for those first couple to few months. Now, life happens around that. A couple to few months. On one hand, when it's over, seems like a really short time, but when you're facing it, seems like a really long time. So I would say that you do your best to protect everything as best you can, but sometimes things happen and you just have to kind of get on with life. In general, we're talking about just nothing strenuous. We want you, after all of these surgeries, to be able to do activities of daily living, get up, move around, tinker around the house, but not do a lot of heavy work. We want patients walking, even the day of surgery, the day after surgery, even with the biggest surgeries that we do related to the breast. We want that to happen. And generally, patients feel, no matter what type of surgery we're talking about related to breast implants or even breast in general, patients feel fairly good within, I would say, the first few days to couple of weeks, depending on what that surgery is. So you're probably going to feel like you want to do more faster than what the body really wants you to do. But another thing I think just to throw out there in terms of thinking about recovery, even a little surgery is a big impact on the body. So if even 6 months, 8 months, a long time after a surgery, you're still feeling like, gosh, I'm more tired than I used to be. I just can't quite do as much as I used to. That's probably okay. Now you may want to check with primary care doctor, make sure you're not anemic, et cetera, et cetera. But a lot of times it just is that the body's still trying to recover, even though the mind has recovered long before, the body might still hang around working on it for a little longer. And is the age restriction on implant surgery. There are different sort of recommendations for implants and types of implants related to age. So, if a patient's very young, they may be recommended to have a saline implant rather than a silicone implant. And there are a lot of, in terms of age, there's a lot of thought about sort of what else is it besides just the implant, but we have to think about a lot of different things at any part. Any kind of point along the age spectrum. So, our young patients have one set of considerations, our pretty young patients have another set of considerations, our getting to be not so young patients have another set of considerations, et cetera, et cetera, et cetera, as you go through life. It's always just a little bit of a different thought. And that's what I was saying earlier. We really, really want to think about everybody as an individual. So we're trying our best not to over group patients. We need to some extent to be able to kind of predict risk, et cetera, but nobody's average. Everybody's unique, and we have to keep that in mind. And that's why these conversations, when we're thinking about implant placement, are so intense because we really need to think about what do we have as education to provide? What do our patients have to tell us about what they're really hoping to achieve? And how can we come together and get that to work? What is a breast ultrasound, and is this something people with implants should get regularly? My doctor didn't mention it to me, but I've seen it discussed on some online communities. So there are a variety of different ways to image a breast. One is an ultrasound, another is a mammogram, another is an MRI. You can do other things, but those are kind of the three that we probably talk about most commonly. If so, current recommendations from the FDA are to monitor a silicone breast implant. I alluded to the fact that they have changed over time, and just know that the silicone implants are recommended for imaging. Well, the actual recommendation is the FDA says that for patients with implants without symptoms, an ultrasound could be done or an MRI could be done for surveillance. Now, with symptoms, it's usually recommended that an MRI be done. So it's possible that what you're reading about online and through chats is patients talking about having surveillance ultrasounds performed. Now, ultrasound can also be used as a diagnostic tool if a lump is found or concerning findings on the other imaging. Sometimes an ultrasound can help define that picture as well. So I'm guessing it's probably the first situation where it's an surveillance ultrasound if people are kind of talking about it generally as related to implants. Our next question is, can I have an implant placed right away at the time of mastectomy? Yes. You can also have a temporary tissue expander placed right away at the time of mastectomy, which is a changeable volume implant that can be put with less volume. So there's maybe, kind of less need to sort of force the skin to do what the implant wants to do. Or you can have it placed later. There are goods and bads about each of those methods. Probably the thing that is I guess I would say the holdup most of the time when an implant is not placed immediately at the time of mastectomy is just that worry about the blood supply. So, different plastic surgery practices approach that concern differently, but immediate implant placement is definitely a tool that we have in our toolbox. Is it possible to get implants, but they jiggle as I walk like my natural breasts? From research, a lot of people comment that implants are quite rigid. I would say both are true. So the goal, the desire for a breast implant is for it to be not really much firmer than the native breast tissue, and to have enough native breast tissue over top that that implant is sort of just bulking things up and the breast feels and looks natural on top of it. Um, Different formulations of implants, the gels and the saline, I suppose, but mainly it's talked about with the gel implants. There are different firmnesses associated with different cohesiveness, which is kind of a way that the companies are working to sort of either prevent leak, or I won't say prevent, to decrease the risk of leak, or to sort of force resistant soft tissue to do what the implant wants it to do. So the more cohesive the gel, probably the firmer the implants feel. The textured implants, which are still used sometimes, they tend to kind of stick to the soft tissue a little bit more like Velcro. It's not a good analogy, but it's a little bit more like Velcro rather than just a smooth rubbing thing. So those patients felt that when they were being placed regularly, felt that those were a little bit firmer. Um, it's definitely true. Some patients feel that they are firmer or more rigid, but then other patients don't. A lot of patients don't really notice the implant being in. So I think that's one where it's kind of an individual awareness and very hard to know how one's own mind is going to react to the implant and what you're going to sense. Kind of like, some people's feet are probably more or less sensitive to having a pebble in the shoe type situation, or different fingers can tolerate hotter or colder materials without suffering. If you had an expander infection and the expander was removed, what are your recommendations for future implants? It depends a little bit to answer this by, or it's really depends a little bit on what the soft tissue is like after that infection. So, generally, I would say if it was a passing infection that got treated, the implant is out, and the soft tissues had a bit of time to rest and feel like the infection's really good and cleared, then pretty much all of the implant options should still be open. There may be different, reasons why that's not true, but generally, I would say I would think of it as pretty much all the options are available. Possibly you could say that, well, maybe there's a little more scarring in the soft tissue. Maybe it's not as elastic and, pliable as normally. And in that case, maybe you might have to step down a little bit in terms of size from what maybe was initially planned. That does sometimes happen. Then we have another question here. Will nipple sensation be affected by surgery with innovation? We do have more and more availability of nerve supporting techniques, I guess is the best way to say it. So at the time of mastectomy or even after, sometimes the nerves that are cut can either kind of be rehooked up, or nerve grafts can be used, or when we're transferring, I know it's off topic because we're talking about implants, but when a patient's own tissue is being transferred for autologous reconstruction, sometimes nerves can be connected there. All of these innovative surgeries are designed to try and help bring back some of the sensation that is lost during a mastectomy. And it's even important after aesthetic surgery as well, because sometimes, a nipple, even though we're working farther away from it than we are during mastectomy and reconstruction, nipple and areola, or there can be, changes to sensation of the skin around the incision or the nipple and areola. So those are important questions for aesthetic as well as reconstruction surgery. Then the next question is, what causes rippling at the top of my breasts after reconstruction surgery? I'm unhappy about this. Many patients have it and many patients are unhappy about it. The nature of it is just that the skin after a mastectomy is so much thinner than the natural soft tissue there. It's like the thickness of the skin you can pinch on the back of your hand. So any contour of anything that's underneath it can be visible. So the implants are not filled to bursting capacity. So like if they're sitting, and if a sample is sitting on a table, you can see sort of gentle ripples or waves in the top of the implant, not moving waves, but just, the contour itself. So when that skin is really thin on top, you can see the contour of what's underneath it. It can be rippling or wrinkling with an implant. In other reconstruction techniques, there can be other contours that are seen. So, really, our best chance at fixing that is to try and thicken the soft tissue on top. And there are probably most common way of doing it is fat grafting, where we liposuction some other part of the body and then inject it into the soft tissue above, or well, external to the implant. There are other ways of doing it too. There are some acellular matrices that sort of essentially act like biologic felt, I would say, that can help thicken the soft tissue envelope. But that's really most of the time what causes that sort of rippling and wrinkling. Now, it could also be that there's a mismatch between, say, an implant size and the soft tissue envelope around it. So you can think maybe about there's some potential implant changes you can do as well if, for whatever reason, fat grafting or some of the other options of working with the soft tissue are not on the table. You can still try and work with the implant underneath it. I guess I kind of think of it as the implant is like a building block for volume. And then you have this sort of icing on the cake on top, which is the soft tissue. So if you're working on cake shaping, you can either shape the cake or the icing or both to sort of impact how the cake, or, for the analogy, the breast looks. And I think we're getting close, but we may have time for one last question. Yes, I'm 4 months out from mastectomy and reconstruction. I'm still experiencing pain and tightness and not liking the look. Should I have the implant removed? Maybe, but maybe if the pain and tightness isn't too bad right now, you might want to give it a little bit more time. As I was mentioning before, the body takes a lot longer than our mind does to kind of get over what's been done to it. So you might find that with a little bit more time, or even a moderate amount more time, there can be some changes that might make you more comfortable. And depending on what it is about the look that you don't like, it might kind of, Mother Nature might take care of some of that for us. Um, on the other hand, sometimes an implant reconstruction is just not right for a patient, and the patients are just unhappy with them. And in that case, if you're pretty darn sure that you really, for whatever reason, it's not going to change, and your mind right now, waiting indefinitely may not be the right answer either. So it's kind of a hard one for me to really say absolutely yes or no to. I think often, though, we do continue to see some changes, minor changes, not huge changes, but minor changes longer than 4 months after surgery. So you might want to give it a little bit more time. I think we're getting close to running out of time. And I don't know if anybody from the team had anything more to say, but I think that we're about done. I don't see them coming right back on. So I want to say thank you to all of you so much for spending the time. I hope this was a little bit helpful. Everybody's starting from a really different point. So I just tried to kind of get to the things that we get asked a lot about. And that your questions were all wonderful, really hitting to the heart of what this group wants to hear about. So for anybody considering any surgery, good luck with everything. There's a lot to think about. And all of us on the healthcare team side are here to try and help you think through that, sort through it. Do your best to sort of come with questions, but if you think of questions after you talk to whoever's on your team, just reach out again. What our top priority is making sure everybody feels comfortable with the decisions they're making. So, thanks again for spending the time with me.
This will conclude this afternoon's webinar. We apologize if we were not able to answer all questions. If you would still like to have your question answered, please feel free to email hopkinsseminar@jhmi.edu. We would like to thank Dr. Manahan, and thank you everyone for joining today. A recording will be emailed to everyone within the next 2 days. If you are interested in scheduling an appointment, please call the number on your screen. Thank you.
Bye, everybody.